Good afternoon. I'm going to be talking about suicidality in the older adult, assessing and understanding. It's a huge topic, and so of course I won't be able to cover everything, but hopefully by the end of this talk you will have a good understanding of some basics as well as resources on where to go to get more information. I do not have any disclosures of conflicts of interest. So as far as specific topics, I am going to highlight a little bit about depression because that is so important and arguably one of the more common rationales for suicide in older adults. So when I was preparing this, I happened to see that the National Council on Aging has this webinar, which is coming up shortly, but I thought I would highlight it here. This should be a free webinar that everybody could sign up for, and it revolves around community-based strategies for suicide prevention among older adults. And so I'm going to touch on a few things about that, but this is a whole hour and a half designed to really cover that in depth. And I'm a big fan of teaching people to fish, as well as you know, providing a few morsels of fish during a talk. And so you'll notice up at the top here, there's actually the site where this is. And you could say, well, why didn't you just provide a live link where this issue is on preventing suicide in older adults? Well, the reason I don't provide a live link is because in the version of this presentation I gave a couple years ago, I did provide a live link, and I followed it last week when I was preparing for this presentation, and it was broken. So, so I'm showing you the website as well as the content that I'm highlighting. And so SAMHSA, the Substance Abuse and Mental Health Services Administration, as well as the Administration on Aging, have tons of great resources. And this is one of their resources. They also have resources that are specific for tribal nations. And they have training and technical assistance available for those. So I definitely want to highlight these. These are great resources. They're well researched, and they don't always apply directly to older adults, but they are over time increasing the content around older adults. And sometimes we just have to take content that was derived for other populations and try and generalize it. And the Suicide Prevention Resource Center is another one of the national resources that there are, and they have a whole training program. And so I just want to encourage people to review these resources. There's a lot of information out there. Suicide prevention is a top goal nationally and in the state of Oregon. So, and for those suicides that are preventable, you know, this is how we get the information and training so that we can be a part of the solution there. So they have resources and programs, they have fact sheets and issue briefs, they have reports, and then they have resource lists and bibliography, and then they have a nice, you know, you can do searches on their site. So they have information about suicide, effective prevention, news and highlights, and organizations, as well as they clearly publicize the National Suicide Prevention Line. So let's transition into older adults. Well, older adults are not just grayer, slightly shorter versions of adults, just like children are not really small versions of adults. Older adults are really very different as a group, and some of the ways that they're different is they may be likely to be dealing with other issues that can produce thoughts of death much more commonly. I mean, that can happen to any of us, right? A life-threatening illness can happen at any age. It's just when you get older, it is very likely to happen, and there's many different parts of that. So older adults over time tend to get diagnosed with multiple medical conditions, and older adults tend to have lots of pain issues, and pain affects function and autonomy and is so really important and kind of fundamental, I think, to how many Americans anyway, and probably people across the world think of themselves. I think people really want to be autonomous, the vast majority of us. That's really an important value. And we all want to function well. And pain from many different sources accumulates over time. And pain has a very direct relationship to suicide. And I really want to emphasize that point, because I think one of my concerns has always been that the concern about overuse of opiates sometimes leads to inappropriate reluctance to use opiates when they're appropriate. And the group of people who are harmed the most by that are older adults, and even more specifically, older adults with mental illness. And then the other big issue that is common, at least in the United States, is really the social isolation that older adults face. And that can be because they lose their spouse or their loved one. That can be because they can't get around without help. So then your ability to get around is really dependent on lots of things that have nothing to do with you. And then a really common thing about older adults is that they feel like they're a burden to others, even if you don't think that they're a burden or you don't tell them that you think they're a burden. It's a very, very common feeling. And so what other things are different between older adults and younger adults? Well, if you live alone, at any age, of course, but it's more common the older we get. If you live alone, who's going to spot the warning signs? It can be very, very challenging. And there is a generational effect, and we will see how this changes over time if it does. But generations prior to the baby boomers were very unlikely to seek help, especially help around something that they might view as weakness. And so kind of the World War II generation was very stoic, and many of them, they were children of the Depression, or they survived the Depression and World War II, and they just had a really different view of help seeking. The baby boomers, on the other hand, do seem to be more willing to seek help. This is just Maureen Nash's observation here. But I would point out the baby boomers have changed everything about the world and the political climate and really everything about our country over time. So I think that this may change. I think it is in the process of shifting now that baby boomers are aging into the geriatric population. And then the final point here is a lot of older adults don't really necessarily recognize that they need help, and they're very unwilling to talk to someone that they're not already familiar with. And this is why primary care is so important in the mental health care of older adults. The studies to date anyway are very clear. If you refer younger people and older people to specialty mental health, older adults are very unlikely to keep those appointments, much more unlikely than any other group. Again, this may change over time, but that's the current state of affairs. So what do we mean by suicide? Well, sort of the Google.com definition. Suicide is death caused by injuring oneself with the intent to die. And a suicide attempt is when someone harms themselves with the intent to end their life. And this is really important clinically, and it's also a challenge clinically. It's very easy to just assume that any sort of actions that a person takes that are self-harming are suicide attempts, when they may not be. At the same time, there is also often a clinician's predisposition to judge an action as a gesture when in fact it was a real attempt, by looking at what was the lethality of it. What was the lethality of the thing that the person did? And what's more important than the lethality of the thing that the person did is the person's awareness of the lethality. So I, as a physician, I sort of have a list in my head of things that I think are very lethal, and I have a list in my head of things that I don't think of as very lethal, and I think most people would survive. But just because I know that doesn't mean that the general public knows that. And I think you have to really take a clear look at that. It's really hard because you're making judgments about a person's internal motivation, and it's a judgment call. And judgment calls are always somewhat of a challenge. Most suicides are related to psychiatric disease, with the big players in the room of major depressive disorder, bipolar disorder with depression, substance use disorders, and chronic psychotic illnesses. So the vast majority, more than 90% of people who kill themselves by suicide have a mental disorder. But I do want to always point out the flip side. The vast majority of people with mental illness do not die of suicide. So even though that's the group who's at risk, even in that group, it's not super common. It's not uncommon, but it's not super common. And with older adults in particular, it's very, very important to pay attention to the words. And so, if somebody says, I wish I was dead, that is not a suicidal statement. If somebody says, I would be better off dead, that is not necessarily a suicidal statement. And if somebody says, the world would be better off if I was dead, that isn't directly suicidal, but you really have to wonder, is there a component of excessive guilt there, which is one of the major symptoms of a major depressive episode. So you have to really listen carefully, especially with older adults, about death wishes. You have to listen to, what it is that they're talking about and decide, is it suicidal ideation? Are they talking about sort of non-fatal suicidal behavior or self-harm kind of things? Or are they really thinking and talking about suicide? And again, you have to really train your ear and listen closely and just talk. Gosh, when you say that, I really wonder what it is you're thinking. Gee, I hear when you say that, blah, 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 and it makes me worried. Can you tell me more about that? So instead of maybe necessarily just inferring, ask other people, ask them what it is that they're meaning, and see if you can get them talking about it. That'll give you much more insight into what's really going on in their head. And I want to point out, there is a very, in some quarters, very controversial topic, and that's death with dignity. And then a somewhat related issue is physician-aided death. And I'm not going to spend time during this talk on that. It's really kind of an ethics presentation, if you will. But I want to say what I'm talking about today really doesn't apply to those people who make a decision to kill themselves unrelated to a mental illness. That is a very different, that meets the definition of suicide if somebody chooses to kill themselves purposefully, but it doesn't make it sort of one of those possibly preventable kinds of suicide related to mental illness. So you can't improve the mental health system and decrease the risk of that kind of death. And the Oregon statutes are very clear that assisted death with dignity is not suicide. Now that's a very particular kind of death. But I think it's in the same vein as some people who have a terminal illness, for instance, choose to end their life. And if they don't have a mental illness, it's not totally clear that there's evidence that that's preventable. So for those people who do have a mental illness, which is who we're talking about today, and older adults, what kind of strategies might decrease the risk? Well, there's always that primary, secondary, tertiary prevention kind of things. So strategy one is just promoting emotional health. And for older adults in particular, it's really important for older adults to have positive social connections. This is actually quite similar to children and all adults, but what's different about older adults is that there are fewer opportunities for some older adults because of the social isolation. And so the things that we can do to improve community connections and connections between neighbors and connections between kind of people with like-minded interests, positive social connections is so important for older adults. And it is, there's a fair amount of indirect evidence that this intervention, this type of intervention, can decrease the risk of suicide in older adults. Sort of the secondary strategy is recognize and respond to suicide risk, which I think we spend a lot of time being trained on in healthcare about that. And I think that one of the things to know about is any suicide attempt is a risk factor, but the more recent the suicide attempt, the greater the risk. If a person has both a mental illness and a substance use disorder, then that is really kind of a multiplicative risk. And when you identify somebody who appears to be at a higher risk of suicide, linking them to sources of help is very important. And then kind of the last ditch strategy, which is where we spend a fair amount of energy, I think, and where it's always harder to tell if we can make a big impact, but is the responding to a suicide attempt or a death. And when there is a suicide, for instance, like in an assisted living facility or a residential care facility or an adult foster home, adult care home, that has a huge impact on all the other residents as well as families and caregivers. Suicide attempts likewise can have an impact. And really the impact on me as a caregiver or me as a family member or me as a resident is going to be both based on my own personal history as well as my relationship to the person who died or tried to kill themselves. And it's also going to be really majorly impacted by how much support I feel from others around me. And so it is really, really important to wrap around people in communities as well as the whole community when this happens. And certainly if somebody is living alone, it can have an impact on families and if there is a caregiver, but it's there are fewer people than when you have a congregate living setting. But it's don't forget staff, because by shoring up and supporting staff members, they're the people who are going to be able to support others. So how do we know when somebody is at immediate risk of suicide? Well, the easiest way is when somebody says something like, I'm going to go to the store X, and I'm going to buy a gun, and I'm going to come home, and I'm going to shoot myself. Right, so that is pretty clear cut and leaves very little room for doubt about what the person is thinking about. But most of the time we don't get that kind of clear cut thing. So talking about wanting to die or to kill oneself is certainly a key there. And I think it really, it's not talking about death, but it's talking about wanting to die. And you really, it's very important to, for professionals to tease out, you know, is this about wishing I was dead because I'm suffering so much or because of this or that, or do I actually want to be dead? And there is a subtle but real distinction between those two things. You know, looking for a way to kill oneself, you know, so asking about knives, obtaining a gun, hoarding pills, researching hanging, you know. And then the other thing is the biggest kind of emotional risk for immediate risk of suicide is hopelessness. There have been 2 situations in my life where I was the last clinician to talk to someone who killed themselves. And one of those people was in an emergency department. And what I remember about that encounter is the really profound sense of hopelessness that that person had. And I don't think I had ever been in a room with anyone else who had such a profound sense of hopelessness. And so I think that is really paying attention to that, and a person talking about not having any reasons to live. So that's great. You hear those things. Those are relatively, it's a small list and it's relatively clear cut. What about other sort of serious but less immediate risks? And this is a very important list because these are the things that are potentially modifiable. And these are what I want you to really pay attention to. This might be the most important slide, in my opinion, besides the resources at the beginning. This might be one of the most important slides in the whole presentation here. It's because these are the things that you can pay attention to in people who have chronic psychotic use, chronic psychotic disorders, or substance use, or people who have serious mental illness, major depression, or bipolar disorder. When you hear about these things, these are areas where we can make interventions possibly. And so, and the time that they're most notable is not if somebody has talked every day for 50 years about being a burden to others. It's not that they don't feel like they're a burden to others, but it's more difficult to understand what to do with that information. Whereas if somebody has never talked about it, now they're talking about it, that is that's what puts it into a serious level. So, and this is the list. So talking about feeling trapped or being in unbearable pain, and it can be really important to figure out whether it's unbearable emotional or physical pain or both. The sense of being a burden is really a key thing for many older adults. Increasing use of alcohol and drugs, not necessarily because of the substance use itself as much as because of the some of the disinhibition and the brain changes that come with being intoxicated. Those can increase your risk of suicide. Behaving recklessly, people who are psychomotor agitated, so pacing, wringing your hands, just kind of that restless energy. That restless energy often needs to go somewhere, and what we as clinicians want to do is figure out how to help a person channel it so it's not going towards planning for and completing a suicide. Sleep is really, really key, and one of the things that I have found in just with the people I've worked with, the thing that seems to push people over the edge at the end is often either an inability to sit still or an inability to sleep. And so sleeping is very key. It's a very common and a very important symptom of mental illness, and it's very important to pay attention to it. And it's very, very common that it's a challenge for older adults to sleep. Feeling isolated and withdrawing purposefully. So that's different than being isolated, right? Some people kind of prefer their own company more than others. Some prefer their own company most of the time. Other people just really always like to be around other people. So you have to look at the change from baseline a little bit, but that feeling isolated. Showing rage or talking about seeking revenge, and that you have to probe that one a little bit more, but you can see that. And then extreme mood swings. So these are things that really should cause you to develop an action plan with your patient or client. So what can we do about the isolation? Well, there's a couple resources. So the Friendship Line is the Institute on Aging. It's a crisis and a warm line. And sort of they describe themselves as being a place for anybody who's lonely, isolated, grieving, depressed, anxious, or thinking about suicide or death. And there's their phone number. And you can, as a professional, you can actually contact them, and they will on a weekend make a call to an outgoing call to someone. You have to be really, you want to be mindful and planful about that and get a person's consent, but you can do that. The Senior Loneliness Line is a statewide service provided by Lines for Life and the Oregon Health Authority. It's for anyone age 55 and older. And they focus on preventing substance use disorders and suicide, as well as promoting mental wellness. And so this is, these are their phone numbers. So I'm not going to spend a lot of time on this, but I really want to highlight depression. When we talk about depression in this context, and even in most contexts, we are not talking about sadness or feeling down and blue. We're really talking about an illness. We're talking about there are multiple symptoms that go along with depressive illness, and they are pervasive, persistent, and cover a large range of things. It is clearly a brain disease. And I always worry that our use of, I'm depressed today, or, I'm down. I worry sometimes that because we use those words so freely in our culture, that sometimes it takes away from understanding that depression as part of a psychiatric illness is a totally different beast than just what everyone experiences at some point in their life. And so it involves changing the way you think. So the negative views, the worthlessness, feeling incapable of doing this, excessive sleep. It changes, your brain changes, and that changes multiple things in your physiology, including your sleep, your diurnal mood variation. People with severe major depressive disorder almost always feel worse in the morning, and it tends to get slightly better as the day goes on, and that's a very worrisome sign if it stops getting better at all. And it impacts energy and concentration, working, your ability to relate to other people. It impacts your movements. People with severe major depressive episodes walk and talk slow. They have this negative filter on all of their thoughts, and often get to a point where the only thing they can think about is death or suicide. In older adults, a lot of times there is this fear or belief of bodily illness. So people with a major depressive episode can have a symptom like a cough and jump to the conclusion that they have lung cancer, for instance. So depressive illness, the biggest things really are your personal previous history of a major depressive episode, your family's history, genetic factors, and then it's not that a loss of, say, a spouse or a stressful life event or even a lack of social support, it causes a depressive illness, but they, in the stress diathesis model, when you put more stress on the central nervous system, it will break in certain ways. And if you have the right genes and the right family history and the right personal history, or wrong, if you will, when you are under these kind of stresses, you are much more likely to have a major depressive episode. So ICD-10 criteria is pretty straightforward and it's easy to answer. We don't tend to use them in this country, but clinically, even though they are used for coding. But what I like about them is that they're very straightforward questions, a lot of yes/no questions, and then they give you a way to come up with mild, moderate, or severe. And so questions 5 and questions 9 are the two questions that they highlight as the most significant as far as moderate and severe major depressive episodes. There's a lot of types of depressive disease out there. There's depressive episodes that don't meet criteria for major depression. It is less clear that they are as risky as a major depressive episode as far as suicide goes, but that doesn't mean they don't have a profoundly negative impact on somebody's life. And then, of course, never forget that many people, in fact, most people with bipolar disorder spend more time depressed than they do manic. There is a small subset of people with bipolar disorder who really only have manic and hypomanic episodes, but most people with bipolar disorder have significant depressive criteria. So the diagnosis is easy to miss in primary care, apparently, and what we see is that of people where it's unrecognized, 50% of those people get better on their own, and 50% of those people are still ill 6 months later. So, and why is that? Well, and this is notable for older adults, they often present with somatic symptoms. So they're complaining about their stomach or their sleep or things that don't necessarily sound like mental illness. They have physical problems. There's stigma, so they're not going to acknowledge any sort of symptom that they consider to be psychiatric. Some older adults don't think that family physicians are the right people to talk to. Some people have been depressed for so many years or decades that they don't recognize that there's anything abnormal about it. And then sometimes people, older adults, have less insight into themselves. What about, and this is, I use the word doctor here loosely, I should change this slide, but to provider or clinician. So what we know about people who are more accurate diagnosers, they make more eye contact. They may be in a hurry, but they show fewer signs of it. They're good listeners, and they ask questions with social and psychological content. Less accurate diagnosers tend to ask, closed questions, yes, no, and they ask a question. Are you having thoughts of killing yourself? Oh, yes, doctor, I am. Okay, great. And how's your sleep? Right? Like that would be a really problematic kind of diagnoser. You want to respond to you ask a question, you get an answer, and you want to respond to that. And sometimes the answer that you get really should derail the whole conversation. And for those of us on a busy schedule, that can be hard. The assessment involves looking at all these things, and I don't think there's nothing new here. And so really the key there is picking up on verbal clues and clarifying them. Can you help me understand that? I'm not quite clear what you mean. Can you share more about that? How did you mean that? And then picking up on the nonverbal clues. And summarizing. Summarizing is a very underutilized tool that we as clinicians use, but summarize what it is you think the person just said to you, and then ask them, did I get that right? Did I miss anything? That does a number of things, including really engaging the patient or client in your interview and in the relationship. And it helps you be more of a partner with them. So dementia, I'm just going to talk a little bit about this. Cognitive impairment, relatively common in older adults. Dementia, common, but not, not certain. Not everybody develops dementia. As far as depression goes, what we have found is that people who are 65 and older often have a major depressive episode in the 2 years prior to the diagnosis of Alzheimer's disease. So for some people with Alzheimer's disease, a major depressive episode is the first sign. And so anytime you have somebody who is 65 or older, especially somebody who has never had a depressive episode in their life before, when they have a major depressive episode, you should certainly diagnose it and treat it. But you should also, in the back of your mind, be cognizant that they may have or be developing a dementia. And so you want to listen to the words, the cadence, the repetition of the language during the interview. And if you have a patient who uses the same 2 or 3 sentences every time you see them, you should really think that is somebody with really significant cognitive impairment until proven otherwise. It's like, that's a tape, right? That's a kind of there's a loop in their brain and they're just verbalizing it. It's really important to explain to patients and families that depressive disease is different from the blues, that it is a brain disease. And it's important to explain that it involves, it's important to explain both to patients and their families the characteristic symptoms, what to watch for. Antidepressants are not addictive or habit forming. That is probably the #1 question I get from older adults about antidepressants. They often take a while to, days to weeks to start working. And they often need to be taken at least 6 months for full benefit to prevent a relapse if it's a first episode. One of the most important things I tell family members and people is, you in the family are going to notice that Mary or John is feeling better long before he feels better. So it turns out it's not helpful for you to say, oh, Mary, John, you look better, because they don't feel better. So that can feel very invalidating. Instead, what you want to do is just continue to encourage and support and not necessarily comment on how somebody is doing until the patient themselves comments that they think they're feeling better. If they tell you they're feeling better, that's when you can comment, you know, I think I've noticed that too, because you're more active and you seem to be resting better and sleeping better. And please note that major depressive disorder is a chronic illness for 50% of the people who have it. And the recommendation is lifelong treatment with antidepressants if a person responded to antidepressants in an earlier episode. Okay. So those are all kind of standard things. Chronic mental illness, you know, chronic mental illness is really, it's such an all-encompassing, and if you have it, it just takes over your life and often much of the lives of your family. And these are generational illnesses many times. And so it just, it causes great stress, great psychosocial stress. Note that you can have new onset mental illness in frail older adults. And so chronic mental illness and the symptoms from that cause suffering, but they may not be the cause of disability in a frail older adult. And so you have to really target your treatment and be aware of that. And then as far as dementia with behavior disturbance, you know, recognize that behavior disturbance is not just kind of this minor thing that not to pay attention to in dementia. It really, it is the cause of most suffering and drives the need for placement outside the home, much more than cognitive impairments do. And so it really is important to track behavior disturbance related to dementia and to treat it. All right, well, I'm just gonna I'm running out of time here. Okay, depression and anxiety are symptoms. They can appear in disorders. The reason we pay attention to whether there's a disorder or not is because it impacts treatment and prognosis. And just know in dementia, depression and anxiety symptoms are very, very common, but new onset depressive or anxiety disorders is actually fairly rare. What about an anti-suicide pill? Wouldn't that be great? Well, suicide is a challenge to study. It's a relatively rare event, and it is challenging to predict, right? We can say, oh, these are all people at risk, but most of those people at risk are not going to kill themselves. It itself, suicide isn't an illness or disease itself, so that makes it challenging. I want to just point out that there are 2 medications that have been shown to decrease the risk of completed suicide, and that's lithium and clozapine. And they're not actually very new medicines, but lithium has been shown to decrease the risk of suicide and mortality in people with both unipolar and bipolar depressive disorders, and that's regardless of gender or age. And it's not clear that it's related to its mood stabilizing effects. So there's a significant reduction in the number of suicide attempts among individuals who take lithium, even in those who don't respond, you know, who don't become stable with their bipolar disorder or their depression, major depressive disorder, when they take lithium. And interestingly, you know, even in places in the world where there's lithium in the water, because lithium is a salt like sodium chloride, and so some places have lithium in the water, suicide rates are much lower in communities that have lithium in their water. So there really is something about lithium. And then clozapine. As far as people with chronic psychotic illness, people who have schizophrenia or bipolar disorder, schizoaffective disorder, clozapine by far is the most effective medicine we have ever seen. And there's really nothing even remotely close to it as far as improvements in cognition that occur with clozapine. It's approved for treatment-resistant schizophrenia, and the reduction in risk in suicide is very, very profound. And it is the only antipsychotic that has FDA approval to treat suicidal behaviors. How powerful is that impact? Well, and I'm not sure if people will recognize this, but they took a group of people and they treated one group with Clozapine and they treated one group with olanzapine. And serious suicide attempts and hospitalizations for suicidality were reduced by 1 in 4 for those people who were on Clozapine. So we know that for people with chronic psychotic illness, being in treatment and having treatment relationships decreases your risk of suicide. But this is sort of, this is an amazing statistic, and I can't really overestimate. To decrease the risk by 25% with Clozapine is pretty much unheard of. And so I really, it's very underutilized as a medication. It is hard to take. It does have lots of side effects, but the benefits of this medication, if you can take it, far outweigh the drawbacks, and they are very profound, both for cognition and suicide. All right, and so here's just some references. So, and I have some time here for some questions. So let me see if I can go over these. Yes, SPRC has some great older adult material. Absolutely. Are there specific medical conditions that might contribute towards higher suicidal ideation, such as a cancer diagnosis? You know, any terminal illness seems to be associated with completed suicide. You know, this question is specifically about suicidal ideation, and that's suicidal ideation is exceedingly common, and so that's a little bit, I'm not aware of data about specific diagnoses associated with higher suicidal ideation, but for completed suicide, a terminal illness and chronic pain and acute on chronic pain, as well as sleep disturbance. Those are sort of the biggest general medical conditions associated with completed suicide. Do you know any statistics regarding Parkinson's disease and its common cognitive and psychotic symptoms that often accompany the disease as related to suicide? Off the top of my head, I do not know the statistics. I do know, and I did a presentation on Parkinson's disease as part of this maybe a year or two ago, but it was a presentation on neuropsychiatric disease in general. So Parkinson's disease, well more than 50%, probably 90% of the time, does involve some psychotic symptoms and cognitive symptoms. It always involves cognitive symptoms if you have it long enough. Parkinson's disease causes slowness of thought. So it makes it, so you really have to wait a long time for people to think things through. You have to wait a long time for people to move when they have Parkinson's disease. And psychotic symptoms are exceedingly common in Parkinson's disease and other Lewy body diseases. So Lewy body, Parkinson's disease is a Lewy body disease. There are abnormal Lewy bodies in the brains of people with Parkinson's disease, just like there are abnormal Lewy bodies in the brains of people with Lewy body dementia. So it's nearly universal, but I don't have an actual statistic memorized. And as far as suicide, Parkinson's disease definitely does have an increased risk of suicide. You know, it's a fatal progressive disease, and it definitely impacts a lot of a person's life and their quality of life. And so it definitely is one of those things that does have a higher risk of suicide. Are there any other questions? All right. Well, thank you everyone for your attention, and I really appreciate your calling in to or joining online the presentation.